Welcome to this deep dive, custom tailored exactly for you. Today, we're exploring something that, well, it affects so many of us, or maybe someone we love, but it's incredibly misunderstood. We've got our hands on the brand new, highly anticipated hip pain and mobility deficits, hip osteoarthritis, revision 2025 clinical practice guidelines. And this was just published by the American Physical Therapy Association, specifically their Orthopaedics Academy.
Yeah, and to give you an idea of what we're looking at here, this is not just some casual summary article you'd find online.
Right.
This is a dense, rigorously researched clinical practice guideline document. It basically synthesizes all the randomized controlled trials and the systematic reviews right up to late 2024.
Wow.
It details exactly what works and, just as importantly, what absolutely does not work for treating hip osteoarthritis.
And our mission for this deep dive is pretty simple. We are going to extract the ultimate evidence-based playbook for managing hip pain. Whether you're dealing with a creaky hip yourself right now, or maybe you're prepping to help a family member navigate their physical therapy, or, and I know a lot of you are like this, you're just an insanely curious learner who loves understanding the biomechanics of the human body.
Yeah.
This is your shortcut. You're going to be fully informed on the absolute cutting edge of joint rehab without having to slog through a 30-page medical journal.
And it's incredibly empowering information.
Yeah.
We're moving far beyond the old advice of just go home, rest, and take an ibuprofen.
Oh, for sure.
The science has evolved massively, and these guidelines map out a much more proactive, highly individualized approach to care.
Okay, let's unpack this, because we really need to talk about the sheer scale of the problem first.
It's big.
According to the data in these guidelines, hip osteoarthritis, or OA, affects 19.6% of the over 55 population in the U.S. alone.
Which is huge.
That is nearly 1 in 5 people walking around with this specific joint degradation.
It is. And for a long time, the prevailing narrative was that osteoarthritis was simply wear and tear.
Like rust.
Right, like the inevitable rusting of the body's hinges.
Yeah.
People thought of it like tires wearing down on a car. But these 2025 guidelines really drive home that we need to view this as a complex mechanical dysfunction.
Meaning it's active, not passive.
Exactly. It's a biological and mechanical process that affects not just the joint space where the cartilage is, but the entire surrounding musculature. Your muscles, your ligaments, the way you move it, all degrades in tandem with the joint if it isn't actively managed.
And that is exactly why we're doing this deep dive for you, the listener. We want to arm you with the specific science-backed interventions that actually move the needle on pain and mobility.
Because knowing this stuff can save you so much time.
Time, frustration, and honestly, potentially a lot of unnecessary medical costs. But before we get into the solutions, what does this actually look like in the clinic? Because the text mentions that the classic presentation usually starts with anterior groin pain, which I have to say is really counterintuitive for a lot of people. When we say hip, we usually grab the side of our glutes or maybe our lower back.
It's a very common misconception. The joint itself is actually buried much deeper in the front of the pelvis.
Oh, I see.
Yeah, which is why that deep groin pain is the true red flag for hip OA. The pain typically worsens with weight-bearing activities. We're talking about the basic mechanics of daily living, walking, taking the stairs, standing for long periods.
And alongside that pain, the guidelines note that people usually experience a loss of internal rotation and flexion.
Right.
So in practical terms, that means it gets harder to pivot your leg inward or pull your knee up towards your chest, right?
Exactly.
So just putting on your shoes and socks becomes this whole ordeal, or swinging your leg out of the car suddenly takes a ton of effort.
That's the functional loss we see early on.
Yeah.
And if it's left unchecked, the guidelines describe a real cascading progression. You might start experiencing joint crepitus.
The crunch.
Yeah, crepitus is the medical term for those crunching, grinding sounds coming from the joint. And from there, the walking pattern completely changes. The document details the development of an antalgic gait, or a Trendelenburg gait.
Let's break this down for the listener, because those are pretty heavy clinical terms. What are we actually seeing when someone has an antalgic or Trendelenburg gait?
Well, an antalgic gait is essentially a severe limp.
Okay.
Your body intuitively shortens the amount of time you spend standing on the painful leg to avoid loading the joint. A Trendelenburg gait is a bit different. It happens when your hip visibly drops on one side when you take a step.
Like a dip in the walk.
Right. That occurs because your glute muscles on the side of the arthritic hip have become too weak to hold your pelvis level, so the mechanics of your entire lower body start to compensate.
And before we get to the interventions to fix those mechanics, there's a concept in the diagnostic section of these guidelines that completely reframes how we should even be measuring a hip.
Oh, this is a great part.
It's such a cool concept. It's the idea of hiption, like HIPTION.
What's fascinating here is that we have long accepted a concept called scaption for the shoulder.
Yike.
The shoulder blade sits at a specific, slightly forward angle on the rib cage. Because of that natural anatomy, the most natural plane of elevation for your arm isn't straight out to the side or straight out in front. It's somewhere in between.
Right, on that diagonal.
Exactly.
Yeah.
That natural anatomical plane is scaption. These 2025 guidelines emphasize that the hip has a similar dynamic, but it is deeply individualized to every single person.
Because of how uniquely our pelvic bones are shaped.
Yes.
The guidelines point out that standard range of motion assessments might actually be overlooking natural variations in our skeletal architecture. They talk about femoral version and acetabular alignment. Can we visualize that for a second?
Sure. Imagine the classic ball and socket joint. The acetabulum is the socket on your pelvis, and the femoral head is the ball at the top of your thigh bone. For some people, that socket points slightly more forward. For others, it's angled a bit deeper or wider. And the version refers to the specific twist of the thigh bone itself.
Like how much it naturally rotates.
Right. Because of those unique angles, every individual has a completely unique natural plane of hip motion. That is your hiption.
So if a physical therapist tries to force your leg to move in a perfectly straight line to meet some textbook standard, but your specific socket is actually angled diagonally,
They are basically just grinding bone against bone.
they aren't helping you. They're fighting your actual skeletal structure.
It is a critical paradigm shift in the field. Your normal motion is dictated by the unique shape of your bones. Therapists must tailor their assessments to your specific architecture rather than forcing a one-size-fits-all range of motion standard.
Which brings us perfectly to how we actually see those bones to understand that architecture, which is imaging.
Yes.
The guidelines note a massive update that physical therapists can now directly refer patients for imaging in many regions. That cuts out so much waiting time for the patient.
It speeds up the whole diagnostic process.
And when they look at those x-rays, they're usually grading the osteoarthritis on something called the Kellgren-Lawrence scale, or the KL scale.
The KL scale is the diagnostic gold standard mentioned in the text. It ranges from grade 0, which is a perfectly normal, healthy joint, all the way to grade 4.
And grade 4 is bad.
By the time you reach grade 4, the imaging shows bone-on-bone contact, severe narrowing of the joint space, and marked sclerosis.
Sclerosis being the hardening of the bone underneath the cartilage, right? Because the cushion is gone, so the bone reacts to the friction by getting denser.
That's correct. And at grade 4, you also see large osteophytes, which are bone spurs.
Ouch.
Yeah. The body is essentially trying to grow new bone to stabilize a joint that has become wobbly and painful.
So if you're sitting at a grade 2 or 3 on that KL scale, feeling that stiffness and seeing some of those early bone changes, what do you actually do? Here's where it gets really interesting, because the 2025 guidelines give us the grade A heavy hitters. These are the absolute best, most proven treatments available today, and sitting right at the top of that list is exercise.
But we have to be very clear that it is not just any exercise.
No, definitely not.
The guidelines are highly specific, and this is backed by universal grade A evidence. They have dialed in the exact optimal dosage required to see real change. We're looking at 1 to 5 times per week for 30 to 120 minutes per session over a period of 5 to 16 weeks.
That is a serious structured commitment. You can't just go for a casual stroll on Sunday and call it rehab.
You really can.
The data shows this specific dosage works. But I was also struck by the hierarchy of what kind of exercise works best. The text explicitly states that progressive strength training is superior to Nordic walking.
Yes.
And Nordic walking is superior to unsupervised home-based exercises.
That is a crucial takeaway for you as the listener. Just doing a few generic leg lifts in your living room by yourself is actually the least effective method evaluated.
Which is what everyone does.
Exactly. You need progressive loading, meaning the exercises get consistently harder over time, and ideally you need supervision. The text highlights something called the Tübingen exercise approach.
Right, the Tübingen approach.
This was a specific program that successfully combined physical, social, and cognitive elements to improve hip muscle strength safely over a 12-week period.
Now, the physical part makes total sense to me, but why include social and cognitive elements in a hip rehab program? Are they giving them brain teasers while they do squats?
No, it's more about pain psychology and adherence.
Ah,
The cognitive element involves educating the patient on pain science and body mechanics. When people are in pain, they become afraid to move.
of course.
Teaching them that hurt does not necessarily equal harm allows them to push through therapeutic exercises safely. The social element involved the dynamic between the therapist and the patient, or working in a group setting. It dramatically increases compliance. They aren't just treating the mechanical joint, they're treating the human being attached to it.
That makes total sense. If you understand why you're doing an exercise and you have people keeping you accountable, you're going to get better results.
Absolutely.
The guidelines also give a strong grade A recommendation for aquatic therapy. But I noticed a slight caveat in the data regarding the pool workouts.
Yeah, aquatic therapy is fantastic for overall range of motion, balance, and gait improvements. The buoyancy of the water unloads the joint, allowing people to move in ways they simply cannot on land.
It feels great.
It does. However, the data did note that while people moved much better and had less pain, it didn't drastically change their overall self-reported quality of life scores.
Interesting.
So it's a top-tier option for mobility, but it might not be the single magic bullet for overall life satisfaction.
Okay, so alongside exercise, the other major grade A heavy hitter is manual therapy. This involves the physical therapist using their hands for joint and soft tissue mobilization.
Right.
But again, the 2025 guidelines provide a nuanced update here that completely changes how a patient should experience a physical therapy session.
They break down exactly how much force the therapist should be using, specifically looking at a technique called long axis distraction.
What does that look like?
This is a maneuver where the therapist literally pulls the leg to slightly separate the hip joint surfaces, creating space inside the joint capsule.
And the research found a massive difference between pulling hard and pulling gently.
A crucial distinction. High-force distraction, where the therapist is really stretching the joint capsule past the point of resistance, is best for increasing your overall range of motion.
Okay.
But low-force distraction, where they're pulling gently with no resistance, is significantly superior for reducing pain.
This is such a powerful piece of information for you to take into the clinic.
It really is.
Because if you're in severe acute pain, your nervous system is already on high alert. If a therapist aggressively yanks on your joint to force it to move further, your body is just going to guard and tighten up even more. They should be using low-force techniques first to calm the nervous system down and reduce the pain. Only when that pain is manageable should they switch to high-force techniques to stretch the capsule and get your mobility back.
It perfectly illustrates why customized care is so important. The therapist has to treat the specific impairment, whether that is acute pain or chronic stiffness, that is actually presenting in front of them that day.
So we've established that highly specific exercise and targeted manual therapy are the foundation. But reading through these guidelines, I was struck by some of the more unconventional treatments that now have serious scientific weight behind them.
Oh, yeah.
Let's talk about the new frontier in these guidelines: dry needling.
This is a major update for 2025. Dry needling is now an official Grade A recommendation for mild to moderate hip OA, specifically those Grade 2 and Grade 3 cases on the KL scale we discussed earlier.
Now, for anyone who hasn't seen it, dry needling looks a bit like acupuncture, but it's based on entirely different principles. The guidelines mention they are going after myofascial trigger points, but where exactly are they putting these needles? Are they going right into the hip joint itself?
No, not into the joint space. They are targeting the physical muscle tissues surrounding the hip.
Okay.
A trigger point is essentially a hyper-irritable knot in the muscle band that causes pain and restricts movement. The physical therapist uses an incredibly thin needle. The guidelines specify a 0.2 5x50 millimeter needle, and they use a fast-in, fast-out technique to physically disrupt that tight knot of tissue.
And they are targeting a whole network of muscles to pull this off. It isn't just one spot.
Right.
There's the iliopsoas, which is your deep hip flexor in the front, but they also go after the rectus femoris in your quad, the tensor fasciae latae on the side, and the gluteus medius and minimus in the back.
It shows how interconnected the whole pelvic area is. The impact of releasing those specific muscles is quite profound. The studies show that just a short-term intervention, once a week for 3 weeks, yields massive improvements.
That's incredibly fast.
We're talking about significant increases in muscle extensibility, dramatic pain reduction, better overall function, and even increased muscle force production. By releasing those knots, the muscles can finally contract and stretch the way they are supposed to, which takes the abnormal pressure off the arthritic joint.
3 weeks for that kind of result is incredible. But the guidelines don't just focus on releasing physical tissues with needles. They also look at how we process the pain itself.
If we connect this to the bigger picture, we have to look at the Grade B recommendation for patient education and internet-based pain coping skills training.
Which sounds a little wild at first, using an internet training module for a deteriorating hip joint.
It does, until you look at the mechanism. The source cited a fascinating study utilizing an automated 8-week online pain coping program.
And it actually worked.
Yes. Participants who completed this program significantly improved their perceived function and their coping strategies. It proves a fundamental concept in modern physical therapy. Treating the joint also requires treating how the brain processes pain.
Right, because if your brain is constantly panicking about every twinge in your hip, your muscles will automatically guard, your movement will become rigid, and you will actually experience more pain.
Precisely.
Teaching the brain to process those signals differently, even through an online course, is a critical part of the physical rehab. Now, speaking of things you might not expect to find in a rigorous clinical practice guideline, we have to talk about balneotherapy.
I had a feeling we would end up here. The sulfur baths.
A trip to a hot spring is now scientifically supported.
It is.
A study cited in the alternative treatment section showed that sitting in 36 degrees Celsius, that's about 96.8 degrees Fahrenheit sulfur mineral water for 20 minutes, combined with exercise, yielded better improvements in pain and stiffness at 12 weeks than doing exercise alone. Book the ticket, it's doctor's orders.
Well, let's add a strict caveat there before you start packing your bags.
Fair enough.
The data is fascinating, but it's specifically the combination of the water's properties alongside targeted exercise. You can't just float in a spa and expect your cartilage to heal on its own.
That is a very fair point.
Yeah.
But what is actually happening in that water that makes it so effective when paired with the movement?
It is a combination of factors. The heat increases local blood flow. The hydrostatic pressure of the water reduces swelling and unloads the joint. And the specific sulfur mineral content creates an optimal environment for muscle relaxation.
So it preps the body.
Exactly. When you pair that relaxed, unloaded state with the mechanical work of exercise, the joint responds beautifully.
Okay, we have covered the amazing proven things you should be doing. But the guidelines are also very clear about interventions that have been downgraded or completely cautioned against. Let's look at the what not to do list.
The most significant downgrade in the 2025 revision is therapeutic ultrasound. It has been moved down to a grade D recommendation, which means there is conflicting evidence, and it generally isn't recommended as a standard treatment.
This is huge. For decades, you went to a physical therapy clinic and they rubbed that warm, gooey wand over your hip or your shoulder for 10 minutes. People loved it. It felt like space-age healing. What happened to the science?
The data caught up to the practice. The guidelines point to a rigorous 14-week randomized controlled trial that compared continuous ultrasound, pulsed ultrasound, and a sham placebo ultrasound, where the machine was basically turned off.
Oh, wow. And the results?
The results showed absolutely no significant differences in pain or function between the real ultrasound and the fake one.
Let me translate this for you. Don't waste your time or your money on ultrasound for hip osteoarthritis. The only exception is if it is part of a shared decision-making process where your therapist explicitly tells you, the evidence says this might just be a placebo, but if the warmth makes you feel relaxed before we do our heavy exercise, we can do it. But do not pay out of pocket thinking the sound waves are magically healing your joint.
It is entirely about resource allocation. Your time, energy, and money should be directed toward the grade A interventions that actually create structural and functional change. Another intervention to avoid as a first line of defense is bracing.
Bracing got a grade F. In the context of these guidelines, grade F means it is based on expert opinion that you really shouldn't start there. Why is putting a brace on a painful hip a bad idea?
Because bracing alters your natural biomechanics. If you rely on an external rigid structure to stabilize your hip, your own surrounding muscles don't have to do the work.
And they get weaker.
Over time, that leads to muscle atrophy, which makes the underlying mechanical dysfunction even worse. The guidelines state you should only consider a brace if progressive exercise and manual therapy have completely failed and you absolutely need to do pivoting activities.
Or if both hips are bad, right?
Right. They specifically note it might be considered if you have bilateral OA, meaning arthritis in both hips, and you have no other stabilization options.
And finally, we should touch on weight loss. It remains a solid grade B recommendation. The physics of it make perfect sense. Less weight pushing down equals less compressive force on a degrading joint, especially since forces multiply when you're walking or taking the stairs. But the guidelines are very specific about the target.
They recommend a 5% to 7.5% body weight reduction for those who are overweight, achieved through collaboration with dietitians.
Which is incredibly encouraging. It doesn't require a massive, impossible physiological transformation to see joint relief. Just dropping 5 to 7% of your body weight can change the mechanical load on your hip enough to significantly reduce your daily pain.
That's exactly.
So what does this all mean? Let's bring this deep dive home. When we look at the 2025 APTA guidelines for hip osteoarthritis, they paint a brilliant picture of highly individualized care. The days of being told to just rest, take pain meds, and wait until you need a hip replacement are officially over.
The current science demands a much more proactive playbook.
It is about discovering your unique hiption, understanding how your specific ball and socket are meant to move. It is about committing to progressive, supervised strength training over just doing some generic walking. It's about utilizing specific manual therapies, knowing that low force is for calming pain and high force is for breaking through stiffness.
Yes.
And it's about embracing new frontiers like dry needling for rapid trigger point relief and even training your brain to cope with pain signals.
The most important thing to remember is that this knowledge is only valuable when you apply it. We encourage you to use this data to advocate for yourself in the clinic. When you see a physical therapist, ask them about hiption and your unique pelvic architecture.
Be your own advocate.
Ask for low-force mobilizations if you are in severe pain. Inquire if dry needling is appropriate for your specific muscular presentation. You are now equipped to be an active, highly informed participant in your own recovery.
I love that.
This raises an important question, though, and it's something to really chew on as we wrap up. The 2025 guidelines place this massive new emphasis on hiption. The idea that the natural variance in pelvic morphology and bone alignment completely dictates how your specific hip is supposed to move.
Right.
If our skeletal architecture is truly as uniquely shaped as our fingerprints, where does this lead us? Could the future of physical therapy eventually rely on 3D printing perfect, individualized biomechanical models of your exact pelvis before a therapist even begins their manual therapy? If your bones tell a totally unique story, perhaps the ultimate cure for osteoarthritis lies not just in generalized exercise, but in perfectly reverse engineering your body's specific geometry to create a completely bespoke movement matrix.
That is mind-blowing. Imagine walking into a clinic, they scan you, print a 3D model of your bones and say, here is exactly how you uniquely need to move to avoid every ounce of friction. That is the sci-fi future of rehab right there. And with that, we are wrapping up. Thank you so much for joining us on this deep dive. We celebrate the joy of continuous learning with you, and we remind you to keep exploring, keep questioning, and keep moving.